Good morning, teachers and dear colleagues. Today I'm going to present the topic the role of SERMs in non-metastatic breast cancer. Before starting to speak on SERMs, we'll first have a brief description about the role of estrogen in our body. Estrogen is a very important hormone and it has multiple effects in our body, mainly in our reproductive system. It helps in stimulating the development of breast during puberty, as well as in priming the breast for lactation and future milk production. It also stimulates the maturation of ovaries and helps in this start of a woman's menstrual cycle, and thus in maturing a girl's reproductive system. Also in maturing the vagina, lubrication of the vagina. It has also been found to have a significant role in maintaining the body temperature. It helps in delaying memory loss, and also it has a positive effect on liver and heart by regulating the production of cholesterol. It helps in reducing the buildup of plaque in coronary arteries, and in the case of bone, it helps in preserving the bone density. Further explaining the beneficial as well as harmful effects of estrogen, we saw the multiple benefits of estrogen. The harmful effects, as we all know, it has a major role in the risk of breast cancer, as well as in leading to uterine cancers. Estrogen affects its action mainly by its receptors, and the receptor has two units with the various tissues where estrogen acts as via these two units of the receptors, alpha and beta. In breast, both the alpha and beta receptors play a role, and the other tissues, as can be seen in CNS, blood vessel, bone, heart, ovary, uterus, testis, and prostate. Both alpha and beta units are there, where in liver only the alpha unit, and in lungs, kidney, bladder, and in intestine, the beta unit plays a role. Now, a brief history about how estrogen's role in breast cancer evolved. Mr. George Thomas Beatson, he is considered as the father of endocrine therapy. He noted that first in animals, that by bilateral oophorectomy, there was a significant effect in this disease regression in advanced breast cancers. He reported the case of 3 patients where he found that there was significant tumor regression, and one patient who was inoperable, who had an inoperable breast cancer, even lived up to 4 years. And thus he brought out the paper in Lancet in 1896, showing the effect of bilateral oophorectomy in reducing the disease progression in case of breast cancer. And thus further scientists and doctors led on to study the effects of hormones. Initially, Allen and Edward Doisy found out estrogen and its regulation in the mammary tissue in 1923, and later on by 1967, Harper and Walpole discovered tamoxifen, and which have come on to play a major role in the therapy of breast cancer. Now, what is a SERM? Selective estrogen receptor modulator. As we all know, estrogenic compounds, they have a spectrum of activity. They have full agonistic activity in certain tissues, mixed activity like tamoxifen, which has both agonistic and antagonistic action on tissues, and some compounds like fulvestrant, which has full antagonistic action. Now, SERMs are a group of drugs which are synthetic, non-steroidal, and which has both estrogenic and anti-estrogenic action, and has a role in reducing the breast cancer cell replication. An ideal SERM is one which does not have an increase in risk of uterine or breast cancer. It has a positive effect on the lipids in the cardiovascular system. It prevents bone loss, relieves the premenstrual syndromes, and maintains the cognitive function of the brain. Now, the SERMs can be broadly divided into the tamoxifen, which was the first SERM to be discovered, tamoxifen-like drugs, which includes tamoxifen, toramifene, droloxifene, and idoxifene. And the second major drug, the raloxifene and its similar drugs, which includes lasofoxifene, arzoxifene, and ormeloxifene. Now, coming to our major SERM, which is used in practice, the tamoxifen. It was the first true SERM and it was developed in 1966. Initially, it was used as an oral contraceptive. Later, by the 1970s, it came to play a major role as a treatment modality in metastatic breast cancer and later on as the adjuvant therapy in breast cancer. It is FDA approved, and by 1998, it also came to be used as a prophylactic use in breast cancer. The mechanism of action, it's mainly a competitive inhibitor of estradiol. It inhibits the binding of estradiol to the estrogen receptor, and it initiates a change in the conformation of the estrogen receptor and causes dissociation from the heat shock protein, inhibits the dimerization of the estrogen receptor and further translocation and transcription, and thus it helps in reducing the cell replication of the breast cancer tumor cells, thus having a static and significant static effect. It has a major antagonistic action at the breast and blood vessels, whereas it is agonistic in the uterus, bone, pituitary, and liver. The anti-estrogenic action, as already said, lead on to inhibition of the breast cancer cells. Also, another side effect is hot flushes. The estrogenic effects lead on to in endometrial proliferation, increase in the bone density, decrease in total as well as LDL cholesterol, and increase in the thromboembolic effects. Now, it's a orally effective drug. Its concentration reaches maximum within 3 to 7 hours after ingestion, with an oral bioavailability of 38%. Terminal half-life up to 11 days, and it has extensive tissue distribution, and it's excreted mainly in the bile and stool. Its metabolism, it has a first-pass metabolism, mainly metabolized by the CYP enzymes, the CYP2D6, 3A, 2C9. These enzymes help in the metabolization, and the tamoxifen undergoes enterohepatic circulation and fecal excretion mainly. Now, as in any drug, resistance to tamoxifen has also been seen, which can be either intrinsic or acquired. Acquired usually seen associated with the level of ER. Also, in relation with the HER2 overexpression also has been seen, where the tamoxifen has been found to be less responsive. Also, in around 20% cases, recurrent cases, ER mutation has also been found to play a role in resistance to tamoxifen. But in clinical practice, these molecular levels cannot be assessed only with the clinical recurrence in the patients. We can assume that the patient has a resistance to the drug. Now, this drug has major drug interactions, mainly with the it can be divided as strong inhibitors, moderate, and weak inhibitors. The drugs which inhibit the CYP2D6 can delay the affect the action of tamoxifen. So these drugs may be avoided when tamoxifen is used, or when these drugs are used, tamoxifen effect is less effective. So a drug change or modulation can be advised. These include bupropion, fluoxetine, paroxetine, quinidine, duloxetine, terbinafine, amiodarone, cimetidine. Also, some drugs which induce CYP3 action, such as warfarin, digitoxin, rifampicin, also have found to affect the efficacy of tamoxifen. Therapeutic uses, as we all know, mainly in treatment of breast cancer as well as prevention of breast cancer, also in palliation of metastatic breast cancer. Some non-cancer related uses include treatment of infertility in women with anovulatory disorders, estrogen-related gynecomastia, retroperitoneal fibrosis, and idiopathic sclerosing mesenteritis. Earlier, it was also used in various malignancies, but later on, as newer drugs, newer molecules came into being, its use in other malignancies, their results dwindled, and so discontinued to be used. For example, in earlier in brain, ovarian, melanoma, etc., it was used. Right now, no evidence to prove its efficacy, so it has been discontinued. Now, coming to the major side effects of tamoxifen. Any drug side effects may affect the patient's compliance. So, coming to tamoxifen side effects, the major side effect which is seen in women, as it's a hormonal drug, is the hot flushes experience. It can vary with intensity and duration. It increases over the first 3 months and then it can plateau. It is one of the most common symptoms seen in the women. If we counsel the patient the benefit of tamoxifen, it has been found that ladies tend to comply more, and its effect also decreases over a period of time. Some may not reach the baseline. Still, it has a plateauing effect. If it is severe, we can treat the patients with low dose megestrol, but preferably to avoid hormonal drugs along with it, or antidepressants, anticonvulsants, etc. can be used to decrease the hot flushes and night sweats associated with tamoxifen. Other major side effects include the uterine changes. Mainly, the dreaded one was endometrial carcinoma, but it has found to have a very low risk compared to the benefit of tamoxifen. The risk actually depends upon the duration and dose of the drug. Here, as we can see, with a 10-year use, the risk is 3.1%, whereas in 5 years, 1.6%. And the risk is more with postmenopausal lady and obese ladies. Uterine tumors can either occur as polyps, endometrial hyperplasia, endometrial carcinoma, or very, very rarely even uterine sarcomas. But no trials or evidence to prove the proper incidence, major trials to prove the incidence of these, of sarcoma. Now, coming to the incidence and guidelines for how to manage endometrial carcinoma and tamoxifen, it has been found that the increased relative risk of developing endometrial carcinoma in women taking tamoxifen is 2 to 3 times higher than that of their age-matched population. And as said earlier, it's dose and time dependent. Major trial conducted by the NSABP, the B14, found that when tamoxifen 20 milligram was administered, 1.6 per thousand patients compared with 0.2 had developed endometrial carcinoma when compared with the placebo. But the 5-year disease-free survival from breast cancer was 38% higher in the tamoxifen group than the placebo group. So we can see that the risk of endometrial carcinoma is very, when compared to its benefit, it is very less. An updated version of the NSCBP trials later on described the risk as 1.26 versus 0.58 per thousand. The prevention, so that was in the case of established breast malignancy. So we all know that tamoxifen is also being used as chemopreventive drug. So even when used as chemopreventive, the risk of endometrial carcinoma is there, and the risk ratio using tamoxifen was found to be 2.53 by the in the P1 trial. And this risk is found to be more with postmenopausal women, and the risk ratio is around 4.01 in these older groups. Therefore, the gynecological committee, ACOG committee, they formulated an opinion how to monitor these endometrial changes and what to be done. So they advise that the women, before prescribing tamoxifen, should be informed about the risk of endometrial proliferation, endometrial hyperplasia, cancer, and sarcomas. And they should be encouraged to report any symptoms, vaginal symptoms, such as bleeding, spotting, staining, leukorrhea, or bloody vaginal discharge, which should then be investigated. Postmenopausal women, since they carry a higher risk, should be closely monitored for these symptoms. Whereas in premenopausal women, the risk is not very high, it does not have a known increased risk, and therefore they do not require additional gynecological care unless some symptoms. So unless the patient is identified and have a high risk of endometrial carcinoma, routine endometrial surveillance with any imaging is not advised or recommended. And such surveillance may only lead on to more costly and invasive procedures, and therefore not recommended. But if a patient is developing an endometrial atypical hyperplasia, then appropriate gynecological the use of tamoxifen should be reassessed. If continued use of the tamoxifen therapy is advised and the risks are accepted by the patient, then hysterectomy should be considered in the women with atypical hyperplasia, and tamoxifen may be reinstituted following the hysterectomy as per the initial breast physician's advice, or they may change over to other line of treatment like aromatase inhibitors. In our institution, we are not regularly monitoring the patients unless they are symptomatic. If they are symptomatic, then they'll be evaluated initially with imaging and then further evaluation. Other symptoms include side effects include the vaginal symptoms such as dryness, discharge, menstrual irregularities, retinal toxicity, the risk of thromboembolism. The incidence is very less, but if a patient has a high risk for thromboembolic disorders like DVT, stroke, etc., especially in old age, then it is less preferred to be, these patients are less to be started on tamoxifen. Dermatitis, anorexia, depression are also found, and also in patients with liver derangement also, tamoxifen may be withheld or delayed until the liver function is normalized. So special precaution, tamoxifen should be avoided in pregnancy, and if a patient is taking tamoxifen, they should be advised not to become pregnant, and for that they are advised barrier or non-hormonal contraceptives. And since it has a carryover effect, at least for 2 months after tamoxifen is discontinued, pregnancy should be avoided. It is also not recommended in breastfeeding patients and in porphyric patients, since tamoxifen is associated with acute attacks of porphyria. And also in patients with liver derangement, hepatitis, etc., it's just better to avoid tamoxifen. Now the recommended dosage, it's mainly an oral drug. The commonest form seen is the tablet, and the usual dose is 20 milligram per oral once daily. For those who cannot take tabs, even a liquid formulation is available, almost to the same cost. And 20 milligram equivalent dose will be 10 ml. The major brand names are Nolvadex for the tablet form and Soltamox the liquid form. So for the dosage adjustment in renal failure, there is no need for any dosage adjustment. Whereas in hepatic failure, dose may be adjusted or tamoxifen may be withheld until the patient recovers from the hepatic problem. The efficacy in children is not established. The other major SERM is raloxifene, which is mainly used for the treatment and prevention of osteoporosis. But it has also been extensively studied for its role in breast cancer, both invasive cancer treatment as well as in prevention. Its cardiovascular effects are unequivocal, and it has been found to have a safety profile better than tamoxifen. Its availability is 2%, with similar to tamoxifen. It has an extensive first pass metabolism, but its metabolism is not mediated by the CYP enzyme. Its use, as said earlier, is mainly in osteoporosis. Now, how SERMs evolved to have a major role in breast cancer, the various trials, and how it came to be used in our guidelines. The first, one of the first papers and consensus was by the National Institute of Health way back in 1985. They found that when they studied the effects of adjuvant chemotherapy, they also found that in postmenopausal patients who had hormone receptor positive tumors and axillary nodes positive, various studies showed that they had a higher significant benefit of tamoxifen on the DFS. And those times it was given for 1 year, and even with that 1 year, they found a significant improvement in the DFS. So later on, another major trial was the Nolvadex adjuvant trial, the native trial in 1988. They also found that patients receiving tamoxifen as adjuvant therapy, they had a significant benefit in the DFS, irrespective of the patient's menopausal stage and the ER status, and they advise giving up to 2 years. And additionally, they also found that the OS was also improved, and it was independent of the earlier state factors. Another major trial was by the NSCBP was the B14 trial, which is a randomized trial where they evaluated the role of tamoxifen in patients with node-negative ER positive tumors. It was a randomized trial where around 2,644 patients were included. They half of them were given tamoxifen and half were placebo. Tamoxifen was given postoperatively daily, and they found that patients through 15 years, irrespective of their age, menopausal status, and the ER concentration, had a significant improvement in the recurrence-free survival. And the B20 further established this benefit. In B20, they compared tamoxifen alone plus tamoxifen along with chemotherapy. And when they compared, they found that the chemo plus endocrine therapy showed a significant reduction in the treatment failure of about 65% in all age groups. Again, the results of the NSCBP B14 and 20 combined, the extended follow-up of these patients after 10 years showed that The continued DFS benefit was significantly different, 69% versus 57%, and the survival advantage was 80% in the tamoxifen group when compared to the placebo group, 76%. Now the EBCTCG, with this they conducted various meta-analysis over from their first initiation till the latest cycle. The first cycle was a major breakthrough, where they analyzed around 28 trials where 16,000 women were included and followed up around 5 years. They found a significant reduction in the mortality in the tamoxifen group, and the death rate was found to be reduced by around 1/5. And mainly the older group, people, women over 50 years, were found to be benefited with this therapy. In their subsequent study analysis, they found that it has a significant role in even reducing the contralateral breast cancer incidence, and in risk of endometrial carcinoma was overweighed by the benefit of risk reduction by tamoxifen. Further studies, they found that tamoxifen had a cumulative reduction in mortality, which was more than twice as big at 15 years than at the during the therapy period. That they found that it had a carried over effect up to the next decade, that is up to 15 years. The benefit of tamoxifen was found to be there in ER positive tumors. And the latest one, where 20 trials of 20,000 patients were evaluated. Further, they found the risk reduction over the first 5 years, next 5, and by 10 to 14 years, they found that there was no further gain or loss. This was the analysis was done to know whether an extended therapy was required or not. They found that breast cancer mortality had a uniform reduction by 1/3 during the first 15 years. So also the ER status was the only recorded factor importantly predictive of the proportional reductions for using tamoxifen. And some hidden factors in their analysis was that only 1/6 of the patients allocated had 2 to 3 years of tamoxifen, and 18% of those who were allocated to 5 years also were non-compliant. So even with a lesser duration of tamoxifen, the benefit was found to be significant, and hence they said that if actually all of the included patients had been compliant and had used the exact 5 years of tamoxifen, the benefit would have been much more. Some major trials involving SERM, I'll be detailing further. So the 5 years of using tamoxifen and its benefit was established with the earlier said trials, and it was included in the as part of the treatment. Later on, various trials were conducted to know if 5 years is enough. Increasing the duration of tamoxifen, does it have any effect on the DFS as well as OS? So in UK, the Atlas trial, which was a randomized trial, whether adjuvant tamoxifen longer against shorter, 10 years or stopping at 5 years, was compared. Around 15,000 women were recruited. And finally, 6,000 ER positive patients were randomized. So 3,000 with tamoxifen to be continued for another 5 years, and 3,400 to be to stop tamoxifen at 5 years. So among the ER positive patients, it was found that tamoxifen reduced the risk of breast cancer recurrence. 617 recurrences occurred in the 3,400 women allocated to continue tamoxifen, whereas 711 occurred in those whom it was stopped. Also, there was a reduction in the breast cancer mortality also, with extension of tamoxifen for another 5 years. Hence, they concluded that 10 years of tamoxifen treatment can approximately halve the breast cancer mortality during the second decade after diagnosis. The ATOM trial was a similar trial where they included 6,950 women who had completed 4 years of adjuvant tamoxifen. For them also, 5 more years of tamoxifen versus no treatment was studied. In this, around 39% of the patients who were reported to have a ER positive disease, 53, half of them had node negative disease also. And at a 9 years follow-up, they found that the longer treatment group had a significantly fewer breast cancer recurrence, 28% versus 32%, which can be translated as a 15% reduction in the risk of recurrence. Another trial which studied the extended adjuvant endocrine therapy was the MA17. Here, after 5 years of the postmenopausal women who had hormone receptor positive disease were randomized to letrozole or placebo for 5 years. And after 30 months, they found that letrozole improved the DFS. Here, letrozole as extended therapy was studied. That also found to be have a significant improved distant DFS in the node positive women in both node negative as well as positive, and in node positive women, even OS was found to be improved. Other trials, the NSCBP B42 also evaluated the benefit of additional 5 years of hormonal therapy with letrozole after an initial period with either AI or tamoxifen. And they found that actually there was no non-significant reduction in the DFS, but the improvement in 7-year cumulative incidence was there, both in breast cancer free interval as well as distant recurrence. Other trials similarly conducted were ideal trial and the data trial, but they did not have a significant difference. Still, they had some benefit. They did not show good significant difference in the DFS, but added DFS was improved when they compared it. Now, in ductal carcinoma in situ, tamoxifen can also be used as an adjuvant therapy in DCIS, which was established by the NSCBP B24, which they found that both incidence of ipsilateral as well as contralateral breast cancer was reduced with the use of tamoxifen. Now, coming to the major prevention trials, since it has a major role in the estrogen action, whether they can play a role in preventing cancer in people with high risk was evaluated. And for this, they conducted this major study, the P1 study, where around 13,000 women with increased risk of breast cancer were included. And what was these criteria for selecting the increased risk was those women who are 60 years or older, patients between 35 to 59 years who had a 5-year predicted risk of breast cancer of at least 1.66% with the Gale model, and who had a history of LCS. These patients were included, and they were given randomized into therapy group who received tamoxifen for 5 years and the placebo group. And it was found that tamoxifen reduced the risk of invasive breast cancer by 49%, with a cumulative incidence through 69 months of 43.4 versus 22 per thousand in the placebo group and tamoxifen group. The decreased risk occurred in women mainly 49 years and younger as 44%, 50 to 59, 51%, and for women older 60 years, there was a 55% decreased risk. So tamoxifen was found to reduce the risk of non-invasive breast cancer by 50%, and it was found to reduce the occurrence of ER positive tumors by 69%. But they found that the difference in occurrence of ER negative tumors was not there. It mainly played a role in reducing the risk of ER positive tumors. And they also evaluated the risk of endometrial carcinoma, as I described earlier. Other prevention study, a major study was the International Breast Cancer Intervention Study, where 7,000 women between 35 to 70 years with high risk features were randomized to either receive tamoxifen for 5 years or without or as placebo, and they found a 42% reduction in the risk when tamoxifen was used. Some major other trials using SERMs, the Moore and Co study, where raloxifen's effect was studied. The Root study, again raloxifene was studied against placebo. The STAR trial, where raloxifene is compared with tamoxifen. The Generations and Pearls trial, where other with a median follow-up of 65 months. And from all these trials, they found that when chemo prevention using SERMs was used, there was around 38% reduction in the breast cancer reduction. So when 42 women were treated, we could prevent 1 breast cancer even in the first 10 years of follow-up. Now, raloxifene and tamoxifen, how to choose? Both have been found to be equally effective in reducing the incidence of invasive breast cancer. but raloxifene was found to be less effective in reducing incidence of in situ carcinoma. So it has been advised only in the chemo prevention, not as an adjuvant therapy in established breast cancer. Some basic doubts we may have: can endocrine therapy be used along with radiotherapy? Earlier, when 2D radiotherapy modes were used, it was found that using concurrent endocrine and radiation therapy found to increase pulmonary fibrosis, and hence it was not advisable to give concurrently. But now with the newer modalities of 3D conformational artery, such risk is not there, and so there is no contraindication in starting endocrine therapy along with when the patient is having radiotherapy. Now, can it be given concurrently with chemotherapy? Some trials had been conducted, mainly the SWOG trial. The North American group studied using the benefit of tamoxifen alone, tamoxifen with chemotherapy concurrently and as sequentially. And in their subset analysis, they found that the magnitude of benefit for DFS when the chemo was added to tamoxifen was greater when it was given sequentially than when given concurrently. This may be mainly attributable to the reason that chemo drugs are mainly SIDL drugs, whereas the endocrine has a static action, and so the endocrine may further affect the SIDL action of the chemotherapy drugs. So when giving along with the statistics showing the establishing what I've said now, when chemotherapy is given, it's better to avoid endocrine therapy, and we may start the endocrine therapy at least 3 weeks after stopping of the chemotherapy. Now the NCCN latest NCCN guidelines, what they say about the adjuvant chemotherapy. So for a patient with invasive breast cancer, if they're premenopausal at diagnosis and hormone positive, then tamoxifen may be given for 5 years along with or without ovarian suppression. And if they become postmenopausal, they may either be changed to an aromatase inhibitor for the next 5 years, or may be continued with tamoxifen for a total of 10 years. If they continue to be premenopausal, tamoxifen may be continued for total 10 years, or may be stopped after the first 5 years. Or we can right away start with aromatase inhibitors after ovarian suppression or ablation, and or directly we can start as aromatase inhibitor. Then coming to the case of postmenopausal ladies, they can be started with aromatase inhibitors given for 5 years, may be added with an additional 3 to 5 years, or after the initial 2 to 3 years, it may be continued with tamoxifen, or the patients can be started with tamoxifen initially, and later on 5 years of aromatase inhibitors can be added. And for women who are having contraindication to aromatase inhibitors, we can give them tamoxifen for 5 years or even up to 10 years. The role of ovarian suppression and ablation was studied in the soft and text trials, where they found benefit with ovarian suppression and ablation. Now, the NCCN guidelines regarding DCIS. In DCIS also, endocrine therapy is advised for 5 years post lumpectomy and with or without RT. It's usually tamoxifen for premenopausal ladies. For postmenopausal, either tamoxifen or aromatase inhibitors, according to the patient criteria, can be used. Now, how we follow up in our institute, for premenopausal ladies, usually it is tamoxifen, and postmenopausal, if they are in the postmenopausal group, the criteria, then they are started with AIs, since the various trials on later on trials had showed added benefit with AIs. And if they are initially when starting treatment, if they are premenopausal, they will be started with tamoxifen, and by the end of 3 to 5 years, they'll be checked for their menopausal, the status, menopause status. If they attain menopause, then they'll be switched over to AIs. If the patient has high risk factors like older age group, more than 60 years, node positivity, higher grade, then if there is no contraindication for AIs, here they prefer to give AIs. And in case of the chemo prevention, all these drugs have been advised by ASCO guidelines. Anastrozole 1 mg tamoxifen 20, raloxifene 60, or exemestane 25. They're given for 5 years for patients with high risk. That is those who had a history of atypical hyperplasia or LCAS, who had a breast cancer risk assessment percentage of 3% or more, who has 1 or 2 family members with breast cancer, or the Gale model percentage of 1.6% or more. Thank you.
Thank you, Nisha. Any comments?
Nisha, one question.
Yes, sir.
Is there a role for breast cancer, tamoxifen in breast cancer prevention in men?
Said mainly all these trials have looked into women only. I found the inclusion criteria, all they have written women only.
So men, it is not recommended.
For men, I have to refer, sir.
And second question, if a patient is having BRCA mutation, is there evidence to show that endocrine therapy will be helpful?
Yes, sir. The trial, the prevention trials, they had looked into that factor. When BRCA positivity is there, they have higher risk, and so they advise chemo prevention in BRCA positive people.
Is there a good, basically by BRCA, what's the majority of cancers? Are they hormone receptor positive or negative?
Usually it's a hormone negative, sir.
Yeah, that's why I'm asking. So it's basically, throughout your presentation and throughout the literature, we find that this is helping in receptor positive cases by controlling disease and all.
Yes,
BRCA mutation is negative disease. That's why I asked this question.
so for but BRCA also they had in the US Prevention Task Force and NSBP studies, they had mentioned about BRCA also, and they, even though this risk of ER negative tumors is more, they had advised, since they carry a more risk, they had suggested using chemo prevention.
And in the prevention trials, are there any real evidence of reduction in the mortality, survival advantage?
No, sir. Overall survival, they didn't find the risk reduction they found.
And one more question, last question. In any of these trials, RCC has any role?
Sir, I think the ATTACK trial, I think ATTACK trial we had taken part, sir.
Atlas, yes, surely we are there. I saw name of Bila and Dr. Rajan.
Ma'am had taken part in Atlas. Sorry, sir. ATTACK or Atlas, I was confused.
Okay, thank you.
Nisha.
Yes, sir.
You said that tamoxifen can be used during radiotherapy, but still here we don't use it. Okay.
No, sir. We give. I had discussed with Rajesh, sir.
I discussed with Bila last week, so she said she doesn't give.
Sir, yesterday, since I had this doubt, I asked Rajiv, sir. He told me this explanation of fibrosis risk earlier with 2D, and right now it is not there.
I don't, because I asked the same question to Bila 1 or 2 weeks back. So what she said is that she doesn't give tamoxifen along with radiotherapy. She waits for that. Just confirm that.
Okay, sir. Because Rajesh sir told me, like, I had asked him yesterday. I'll ask all three consultants.
The explanation is correct, but I'm not sure whether they are giving it.
Okay, sir.
There is nothing we can stop it, no?
Okay, sir.
The mortality, morbidity.
And next Monday and on, sir.
Okay.
Thank you, teachers.